So to some of us and many of us here, this has been a long and fantastic week. For those of you who are attending the Expo, this is the day 2 of the SNOMED Expo, and we are now going into the tutorial entitled Building an eHealth Ecosystem for Data Reuse with SNOMED CT. And I would say that this tutorial, or what did we say this morning, Alejandro, this reflection, which is it includes many reflection, is actually a good extension of the plenary session that we have just attended and listening to those great speakers, both from Belgium, but also from the different collaboration initiatives around the globe that is going on. And Tom, I really liked what you said, that a few years ago, not that many years ago, it was all about the modeling of SNOMED and how the quality assurance of the terminology and about the translation. And I would just say this whole experience here in Antwerp really emphasized what you said, that we are now going into the weeds of actual implementation, and that's super exciting, and it's so good progress. Often you say that you want everything to happen tomorrow, and we know when we work in standardization, it's not going to happen tomorrow. So being in the game for many years will actually show that it all pays off, all the efforts. Well, back to this agenda. My name is Randorff Højen. I'm a part of the implementation team at SNOMED International, and together with Kewley, who's sitting there, he'll come up later, and Alejandro Lopez, we form the implementation support team at our organization. And we'll provide, the objective for us is really to show you the different ways we as an organization provide some different kinds of services and have some thoughts to how you can actually support an eHealth ecosystem with SNOMED CT. But besides from our perspective, we also have the pleasure of having the Belgian perspective on this. And we have Mark Helbert and Sofie de Broe. So Mark is from the SAS Hospital Group and Sofie is from CSANO here in Belgium. And they will also contribute to this workshop today or tutorial today, bringing in the Belgian perspective. And I will assume that there's also plenty of people here in the audience who also may have some good input as we go along. So please raise your hands if you have questions. We have separated these 19 minutes into 3. So the first is that I'm going to do a bit of talking here about setting the stage for this whole talk. When I was sitting in the plenary this morning, I was saying, well, that is just that's the background for this talk, why we are doing all of this. But I'll repeat some of things and add a bit. And then we're going into the different elements that we have chosen. It's not a complete overview, but some of the elements that are important aspects as you try to solve some of the issues and impediments that are on the way to achieving good data reuse in an eHealth landscape. And at the end, we are going to have a bit of visionary thoughts about what will the future bring. So the problem. So we need to always, when we have this talk, and maybe we also here in the presenters need to always think about what is it we're achieving? What is our goal? And that is data reuse. Data reuse is something that we have all in this community talked about forever, since digitalization started, and even before. Data reuse has been an urgent matter for clinicians and for other stakeholders contributing to the healthcare. And essentially reusing data, what is it? Someone collects the data at the point of care and someone else uses it, or maybe the same person uses it for a different purpose. Right? So that's the essence, that's what I can bring it down to. What is data reuse? That's as soon as we've recorded something and we then want to use it for other purposes than the primary care, but also for the primary care itself. So this diagram is really just showing that the data can be reused to help inform future decisions. It can be helped to plan the set of different surgeries that we have, or the different tests that are to be taken, or plan the different next step for this individual patient. And some of them are secondary purposes, some of them are primary purposes. And even when we talk about primary purpose, I think we still talk about data reuse. So let's say, and that was what the example today about the patient-centric care is really saying. So even though I am a patient and someone is collecting data for me, we have often talked about primary use of the data is for that encounter and for that patient journey. But as we go along, this world of or the eHealth encounters or different patient journeys, then you will meet different points of contacts that will need to have access to that data. So we're not just talking about reuse is for secondary purposes, no, we're also talking about data reuse for primary purposes. And that's where this eHealth ecosystem is certainly also important to have that in mind, that even I've seen systems where one part of the system was not able to get data from another part of the same system because those two, the way they were modeled, those two user interfaces, and it was stored separately. So you couldn't take it from one module in the same EHR to another module in the same EHR. So even that very tight data reuse would not be possible. Okay, but we want to be able to reuse our data. And essentially, the data reuse aspect is the cherry on top of a very good cake. So how many of you have family members or yourself bake a cake that gets to the stage of having a cherry on the top? It's seldom, right, that we get to that point of really making it look very good and really useful for the sake of the people you've invited or anyone else. We seldom get to that, and it's a pity, because think about all that data we are collecting, and you never get to that point of actually getting to the data reuse aspect. People spending hours and hours and time documenting and capturing data without actually deriving the benefit. What does it take? Well, it takes some good icing, right, to put it on, and you need to be able to ice, and that's where the high quality data comes in. So that is really where I want to put some emphasis in this part of the talk. High quality data. How can we ensure that? Well, when we talk about data quality, there are different measures for data quality. If you look in the scientific papers, there are loads of material on what do we mean when we talk about data quality. These metrics here are some metrics for data quality, and they really apply to also when we implement SNOMED CT. The data needs to be accurate so that the clinician can actually very precisely capture what they mean. They need to be complete. You should not miss out of any important facts that are important for that point of contact or that encounter or that whole care process and treatment process. Consistency is important, and this is super important in the regard of standardization, that you do things consistently. The timeliness, that you have the data available when you need it, whether it is that you can have data available for data capture, but also that when you want to query and analyze, the data is readily available for you. And the fitness for use parameter is indeed important when we talk about, well, the data that you have available, or the codes and terms you have available, are they fit for the purpose that they have to serve? So we talk a lot about terms and how the user interface is designed, but the other part of SNOMED is really about the modeling and how the data can be extracted and retrieved, queried afterwards. And that's also part of fitness for use. Why is data reuse important? Well, for many purposes. For the care, we want to provide the best possible care. For the efficiency of the system, we want to reduce the duplication and admin burdens. We want to make sure that we have a streamlined ecosystem. You'll hear that word a lot in this session. Then we need the good data to enable clinical decision support and support clinicians in making the right decisions for that specific patient, and for innovation and research purposes, so that we can continue to increase our knowledge. So we really want to do a lot with that data. Of course, the point of care is to treat patients, but that, in order to give the best possible care and treatment, we also need to acknowledge all these other aspects, because they are part of achieving that. There's a range of barriers to this, and which are being articulated in these rooms at this Expo very well. Data quality issues. So if you put a minus in front of all the different things that I've just been showing you, then you have issues. If we don't standardize, standardization is key to achieving this. Imagine we hadn't standardized electricity and everything. Where would we be today? So standardization is key. When we work in silos, we also heard that this morning, we are really we are in a bad place in terms of harmonizing what we do, and it will end up with a lot of mapping, a lot of trying to get things that doesn't really fit together to fit together. A lot of other aspects such as resources and cultural differences and interoperability that will be limited of some of the other reasons that I just mentioned. SNOMED CT is an enabler to support many of these parameters for high quality data. It's a common language and it enables data reuse, not only at the front end, but at the back end just as well. But the fact is that SNOMED is not enough. When we started this and when I started doing these tutorials, it was really how SNOMED CT support reuse, but the true story is that it's not about SNOMED on its own, because on its own it does nothing. It needs to be part of a well-integrated ecosystem, and there are different factors that are required to consider: governance, clinical adoption, strategies, integration, and so forth. So it's part of the puzzle, and it's an important part of the puzzle. I almost made it, right? So now I will hand over to Mark, who's going to put a bit of background as well on the challenges that are being faced here in Belgium.
Hello from my side. I would like to share with you some of the experiences at ZAS, Ziekenhuis aan de Stroom, which literally means hospital by the river, referring to the river the Scheldt here in Antwerp. Not because ZAS is particularly special, but because these implementation experiences illustrate the challenges that clinicians and hospitals across Belgium are facing today with real-life SNOMED CT implementation. We are convinced that many of these Belgian issues are likely relevant beyond our small country as well, and we hope that the international audience will find our reflections valuable. So let us begin with the experiences from ZAS. ZAS, just for orientation, spans more than 10 campuses, has over 3,000 hospital beds, 10,000 employees, and more than 1,000 physicians. So it's one of the large hospitals in Europe. In 2022, we transitioned to a new electronic health record, and it was already clear then that the Belgian government would adopt SNOMED CT as the national semantic standard. Therefore, in ZAS, the decision was made to implement SNOMED CT for the core EHR data. And today we will focus on the problem list registration, covering diagnoses, medical history lines, and procedures. We ensured that clinicians were trained to use SNOMED CT within daily documentation workflows. Today, we are 3 years later. And this has resulted in over 5 million problem list entries for patients that have been admitted, more than 85% of them being SNOMED CT coded. While we consider this a success in terms of implementation, it did raise the question, what is the actual return on investment of this effort? To what extent has this demanding implementation really delivered value for clinicians and for others? And we must acknowledge that so far we come to the rather disappointing conclusion that there are almost no tangible benefits for clinicians to date. The reason for this being that neither meaningful reuse nor value-generating interoperability have been operationalized within our Belgian health data ecosystem. It goes without saying that this situation leads to considerable frustration among clinicians, and it poses a real threat to the success of future implementations. So, is this a cause for concern? Well, yes, we believe it is. We all know that clinicians and hospitals all over Europe are facing the huge new challenge, the obligations imposed by the eHDS regulation. Under this regulation, health data will have to be structured, have to be standardized, have to be semantically interoperable, so that they can be meaningfully exchanged and reused, both in the context of patient care and in the context of secondary use. And since the data components of the problem lists are part of the first group of eHDS priority categories, these eHDS obligations will apply from 2029 onwards. That's not so far away. So to be prepared for the eHDS is certainly not a ZAS-specific problem. From our Belgian CMIO network surveys, we know that hospital clinicians in Belgium still operate mainly on unstructured data. We also see that the implementation of SNOMED CT in Belgian hospitals is progressing very slowly. The figure on the right is the result of a survey among more than 50 Belgian hospitals assessing their current status of SNOMED CT implementation. As you can see from this figure, more than 2/3 of hospitals report that they have not yet started with SNOMED CT implementation. Almost half of hospitals report that they don't even have a concrete plan for when they will begin. Keeping in mind that SNOMED CT implementation is not a one-shot thing, but that there is classically a gap of several years starting an implementation and reaching a reasonable level of clinical adoption, this should worry us. On the other hand, clinical adoption is paramount when we accept that structured data capture at the source by clinicians is the best possible way to obtain valuable data both for primary and secondary use. So the answer is becoming clearer and clearer, at least for Belgium. From a hospital and clinician perspective, we are not eHDS ready, and we are not SNOMED CT ready. To become ready, some fundamental challenges in the Belgian health data ecosystem will have to be tackled, in that it must become a more value-generating health data ecosystem. For sake of clarity, we group these challenges into primary use challenges and secondary use challenges. Let's first dive a little deeper into some of these primary use challenges. Challenge number 1. For clinicians, free text documentation still remains the standard, and that's quite understandable. Free text offers clinicians flexibility. It allows them to capture context and nuance as opposed to structured entry. Moreover, structured entry is time-consuming and burdensome. In almost all EHR systems, there is currently a lack of efficient clinical documentation improvement tools that are well integrated into the clinician's workflow. In addition, today's health data ecosystem in Belgium does not support structured data to be exchanged between hospitals or care settings, even for core data elements such as patient problems. This means that the structuring effort has to be repeated from scratch for every patient in every hospital or care setting where this patient presents himself. So it means that clinicians have to redo the same work again and again. Challenge number 2. From our Belgian implementation experience, we also know that there is an important knowledge gap among clinicians on semantic interoperability and SNOMED CT in particular. Medical training in Belgium, both basic and advanced, simply does not address structured documentation and standards. Consequently, there is very limited awareness of the potential, and I consciously stress the word potential, benefits of semantic interoperability among clinicians. The figure on the left shows the answers of Belgian hospitals when asked about their doctor's knowledge about SNOMED CT. 95% of hospitals indicate that their doctor's knowledge is insufficient. 2/3 answer that their doctors have no knowledge of it at all. So the combination of free text as the default and the limited awareness of benefits of structured data risks creating what we call the vicious circle of non-value. Clinicians become less and less willing to invest effort in structured registration, and as a result, the ecosystem drifts further and further away from interoperability and meaningful reuse opportunity. And with this, I give the word to Sophie, and she will guide you through the main challenges in the area of secondary use.
Good morning, everybody. As you can see, 3 times as many challenges for secondary use as for primary. I think I guess if the base is wrong, then you get an exponential effect. So you have data that are not fair. I will explain later for those for whom fair is not familiar. Only once principle not respected. Poor data quality, administrative data influenced by registration purposes, need for robust health data collections for public statistics, government agencies act as silos, slow adoption of standards, limited data access due to privacy concerns, and a lack of vision of data as a public good. But don't get demoralized, there is hope, there is hope. So, what do we mean by data is not fair? In my little world, everybody knows what FAIR stands for, but I'm not sure if that's the case for busy clinicians. So FAIR stands for findable, accessible, interoperable, reusable of digital data. And the ultimate goal is to give value to data. Some people get confused about this idea. They say, what does it actually mean? Well, it's if you register, if you spend public time recording data, registering data, it needs to be also of added value for the general society, for public good. So you need to give value to it, and so that there is information in that data that can serve for secondary or other purposes than just treating the patient. The emphasis here is, of course, machine-readable data. So FAIR implies, in the first instance, and you would be surprised how many organizations do not have this in place, is a complete inventory of your own data. Then you need to describe the data, but metadata, what's in the data. You use a standard that everybody hopefully uses so you can be interoperable, and you need to comply with these technical interoperability requirements. If your data is not fair, there is an opportunity there to verify the data. So for that, you start indeed, and I have to admit, a few years ago I started at Cienzano 4 years ago. There was not a complete inventory of all the data that we had in-house. So we did start by doing that. For those who have heard of the Health Data Agency, sorry for the abbreviation here, this will be the agency that will be responsible for putting at disposition for the whole country a central health data catalog. On top of that, if you want to make your data findable and accessible, you need to make an overview of available health data at organizational level with their descriptions. You need to give an indication of the data quality so people know a little bit of what kind of value is there to this data in terms of quality. And you need to be able to identify your custodian, so the one who is responsible as a data administrator. In the language of interoperability, one likes to speak sometimes of human interoperability. So you have data interoperability. You could consider that human interoperability is knowing which people to talk to, which roles are there in the organization that deal with the data. Then, of course, verification also is interoperable and reusable. So what can I do to make my data interoperable? Implementation of standards, ensuring exchangeability and semantic understanding, the shared meaning, with regards to without additional human effort. Technical compatibility requires a common data model. That's a standardized data model that allows data exchange between different applications and support of linkages between various data sources. So it's a huge task. I don't know if anybody heard about the only once principle, OOP. So the only once principle determines that citizens and businesses provide their data to government authorities only once, after which the authorities are actually responsible for the storage, security, and reuse under strict data protection legislation. But the whole idea around only once is that data should be collected only once at the source to be reused multiple times. That means that as a government, you do not ask organizations to re-enter data that you have already collected in a different instance somewhere else. So you have no double entry requests and therefore no duplications is the way forward, because not only to re-ask the same data in different organizations as a government, you also create an enormous administrative burden, and it also compromises quality because the chance of errors increases, of mismatches between those registrations. I worked in the Netherlands for 7 years. I can assure you the Dutch are rather good at sticking to this principle. So it is possible. We have poor data quality and administrative data influenced by registration purposes. I have put them together a little bit, also part of due to time. We are all very familiar, I think, with the minimal clinical data in Belgium, with ICD-10 coded data for hospital financing, quality monitoring, and policy making. It's based on free text discharge letters, medical records, which are then coded by numerous coders. And we also are, and these are the two big databases, very familiar, I think, with the EMA data, the Intermutualistic Agency, on the nomenclature codes, the nursing activities, care paths, and admission discharge billing details. These are big data sources that are currently being used in the Belgian data ecosystem, reused equally. However, and some of you are very familiar with this, I'm less familiar with this, but we are aware that there are some biases because towards financially rewarding conditions in the minimal clinical data. Another disadvantage is that rare diseases are underreported, so it is not, and that not just. Rare diseases is an interesting one because it's by its nature rare, so not reliable for incidences and prevalences, and there is a delay. It's not suitable for real-time needs, unusable for crisis management, and there is a focus and design issue around it. Excludes primary care and outpatient care, so you don't have the complete picture, of course. The design is financially driven, disconnected from clinical workflows and financial relevance of single admissions as opposed to clinical longitudinal relevance. That's a whole chunk. Equally for EMA data, there are a lot of issues with the data, coding errors, non-specific missing codes, etc. However, this is not just for those data sources. It's a typical characteristic of data and administrative data that are very much influenced by its registration purpose. So these databases were set up with a very specific purpose. And one of the reasons why it's difficult to reuse them, because the data is very much orientated towards this particular purpose. I have to go back because I forgot a very important point that Mark keeps repeating, and I cannot not forget to mention it. So one of the big issues, of course, here for the clinician is that there is no feedback loop. So as these data collections are set up for administrative purposes, you do have a very well organized administrative system that serves the purpose of administration, but the clinician as such, there's no structural feedback loop so that clinicians could get a value out of this data recording. Which is, of course, a missed opportunity. Good. Public statistics, and that's a little bit my field. I come from the area of official statistics, and in official statistics, and I will call it public statistics, the strength there is that you have very clearly defined output. So an official statistic in particular, public statistics a little bit flexible more, is that you have a very clear data output. So you need to make certain output so that the government can run the country. And these are very strongly defined by Europe, but also at the level of the member state. It's done by Stadbel, but in Belgium we have a distributed system, so Cienzano is one of the parties that contributes to making statistics for the country. And one of its strengths is that data is collected, of course, and published by government or authorized bodies for policy research, transparency, and benchmarking. But here you have a very clear legal mandate to produce that statistic. So your organization has a legal mandate, which gives you the leverage to get access to the data you need to produce that output. And because you have the right to access the data to produce that output, because you have the mandate to make that output, you also have an obligation to stick to quality standards, which we call in official statistics is a code of practice. If you Google code of practice official statistics, you will find a very clear guideline on what official statistics should adhere to in terms of rules. So you see that there's a very nice mechanism between legal mandate with a leverage and a right to get access to data, but also an obligation to adhere to quality standards. And this mechanism, I think, can be reinforced even more in the healthcare area. And so public statistics, data collections, you have different ways. You have registers, you have surveys, like the health interview survey done by Cienzano. You have this big data you can use for innovation, and of course, you should be reusing data as much as possible. Yeah, registers are inefficient. I had the honor to be leading the health data platform over the last year, and I can assure you I have learned a lot. Registers have expanded over time to cover many research and policy needs. The primary data sources are insufficiently structured, so require a lot of manual re-entries despite our efforts to do it via APIs. A lack of reuse, of course, of existing data, demands to re-register over and over again data. As a consequence, the violation of the only once principle, big time, a huge administrative burden, large complex data collections, technical challenges, and a fragmentation and overlap between registers. So there's room for improvement. Just a very quick example. Mark and I, together with the people from Health Data Platform, did look at some of those registers, OrthoPride, for example, to check whether any of this data that we are constantly asking is already not existing somewhere else, and it wasn't that easy. Less than 50% of SNOMED CT-based EHR data were meaningfully reusable to populate the register. I will skip, no, sorry, this I will keep it. So another two very important factors, challenges within transforming this, in the attempt to transform a more value-generating health data ecosystem, is government agencies acting as data silos and slow adoption of standards. And indeed, if you look across the data ecosystem, you do see that a lot of government agencies, public institutions, and legally mandated nonprofits each use their own systems, definitions, standards, methods. Now, of course, we have the Health Data Agency that will bring change. The Health Data Agency did a data maturity assessment in 2024, and the general conclusion was indeed that a lot of organizations have a way to go in terms of making their data fair. Resulting, all of that, in registration burden, difficult comparability of data, low quality data, and limited interoperability, and suboptimal population management and research. And finally, the Health Data Agency will solve it all. I have to. We will have this agency, which is mandated by the government to implement the European Health Data Space Regulation. It is responsible for governance of most aspects of the reuse of health data, ensures that a common health data model exists for Belgium, will ensure governance of the national health data catalog, regulates the data request process, and ensures respect, makes sure that there are rules and regulations respecting privacy, legal requirements, and promotes the idea of data solidarity. And I will really want to insist on that last bit, that data solidarity in our current society might not be a concept so straightforward, but it's our relationship with data that is not about personal control, but collective power and responsibility, working together to ensure data is used in an ethical way and benefits everyone. I think that's it for my part. Thank you.
Well, thank you very much. We're a bit late, but I think we will be fine. We will be more quick in the rest of the presentations. So yes, this is it paints like a green picture, but because of these complexities, why these organizations are created. SNOMED was not created because this was simple. This is an organization that was created to try to tackle a very complex issue across nations. And this is why more than 50 countries are collaborating on creating something that will support this kind of implementations. And you can recognize that in the way that the SNOMED services are organized. That is not only the terminology, there's just a lot of things around them. I have an education banner behind me. And in order to overcome all these challenges, you need to have all these specialists thinking about opportunities, designing tools, designing courses, sharing information, and learning from each other. And the first stage is about governance. Yes, and governance is really the key of all this. Mark and Sophie have mentioned a lot about the regulations and the need and how this influence the deployment of these national health services. And in SNOMED, we value a lot the creation of national implementation strategies for terminologies. And we support that. We work with that. We learn from the experience of many countries that have deployed SNOMED nationally. And we have created webinars, workshops that we work with countries to help them build their national roadmaps. And we even have this tool that allows you to play around with components of different roadmaps to combine and create your own roadmap for deploying a terminology. And this is important because when you define the roadmap, you identify your priorities. It helps you coordinate efforts between different government agencies. It tries to identify intermediate goals that you can complete and demonstrate success. You can recognize in which areas you need to improve. you're open to input and contribution from others to your roadmap and to make your roadmap better. And that in general facilitates the budget, facilitates the financial planning. And this roadmap should be completely integrated into your eHealth roadmap, international eHealth roadmap. So based on all that, you need to create a series of implementation activities. And these implementation activities is what people share in conferences like this Expo, yes. You need to understand if you need to adapt your terminology to your local needs to have the best coverage. You need to understand if you will be releasing and distributing terminology packages, if you need a special implementation guide to support implementer, how you formulate the best practice and guidelines to guide people to do the right thing. You commented a lot of bad behaviors and bad patterns that most people want to avoid. And these are the forums in which we can exchange this information. And that's how this organization creates the guidance to try to avoid that. You need to do training. You mentioned this as well when this is awareness of terminology and utility. So it's important to do all that. You can see that this community is a community that you can participate there and you can learn how to improve these things. What's the roadmap that will help you achieve a successful implementation that try to avoid all the common pitfalls. And it's based on pitfalls. It's based on the experience of countries that have challenges and didn't do too well in some aspects, and we learn from that, and we try to share that with the rest of the community. Ideally, you will try to have your extension, and your extension will be representing everything you need. You will have implementation guides. You will have a distribution platform that makes sure that your extension gets everywhere. You'll probably work with other standards like FHIR and explain how your terminology is connected with FHIR. You will have some way to release and make your terminology available to everyone in a very easy way. Maybe you have an NRC, maybe you have a web page, maybe you have terminology servers. But the goal is that it's really simple to go from your needs to the terminology. And you probably need a lot of human work as well. You need to work with the people in your country, in training, in connectathons, in plugathons, in hackathons. These are activities that gather developers, local implementers, hospital leaders, regional leaders together, and they think about these problems. They say, I have this problem. How do you do about this? What are your users complaining about? How you can fix it? And they find creative ways to work around it. And this is a really good thing. And based on this, you need to have tools to monitor this. So you mentioned also about the progress, how if it's slow, if it's fast, and things like that. So you need to have a system that detects when you are slow and allows you to press the accelerator or change direction or implement new things. So we also have this kind of tools like the maturity assessment framework that helps you monitor your progress.
Thank you, Alejandro. So the governance aspect is, of course, super important so that we know where we're going. Otherwise, we'll end up going 10 different directions, and that's the fear. And I don't think you can underestimate what Alejandro is saying there about what it requires to actually bring together the people who are responsible for the local implementations. And I don't think you can do that often enough when you are in a country. It's the same when we are talking about, we're in Europe, talking about EHTS. It's super important that each of the countries keep discussing and talking and agreeing and making decisions. And decisions are not a bad thing here. So sometimes when someone makes a decision, it requires that others will have to bend a bit. And that's what standardization requires. You have to not be so fixed on everything you believe at all the times. In order to get to get somewhere, you also need to be prepared to give something up. And when we do this and talk about what I'm going to address now is how is it that we then get the clinicians and the adoption of a standard into clinical practice so that those locally actually can support what has been decided at a national level. And there are many people that we need to involve in this aspect. So who is it that are meeting and discussing and becoming aware? You spoke about that there is too little knowledge on the floor about why we're doing this. So that is definitely a thing that should be spread. The word should be spread across all these different kinds of stakeholders. And it is a fact that when you have a standard, it's a standard that supports like the general applications. But even a standard, you will find that there's need to customize and tailor the standard to specific use cases and purposes, because it doesn't fit all the use cases. You can't create a standard that fits into every single use case. So you need to think about how your standard can support the local adoption. And at SNOMED International, we have really done a great, I would say, a great piece of work in terms of ensuring that you can actually customize and tailor the terminology while still complying to the standard. So that balance between what is useful at the local level for the special need while still being interoperable. So I would like you to think about these 3 punch words like adapt. You can adapt a standard locally. You can align it nationally, because then it can be reused globally. It can be reused in Belgium if you're here in Belgium, but it can also be shared across to other countries. So how to make sure that when you implement a terminology as SNOMED, think about these. I adapt it so that it fits. I align it to make sure that I follow the national guidelines, and then we can actually get the cherry on the top. And the extension mechanism is one of the means to this. There are different ways you can adapt the terminology, creating local extensions, national extensions, local extensions, so that you can specify concepts that may not be within, if you have a national dictionary, that doesn't mean you can create something locally that you can use to fit a purpose. You can still do that. You can create subsets if the set that has been agreed nationally is way too big for your clinical case. Well, you can actually define what is relevant in your organization. So there are very many ways. If you don't like the terms, create your own terms, but make sure that they actually mean what the concept means. So there are many ways. In terms of terminology binding, so where we actually linked it to linked the terminology to a SNOMED, to an information model, there's also various ways that you can approach that. And then the alignment with eHealth standards. So at SNOMED International, we make sure that we collaborate with other standards. The FIRE open air session that we have the other day is a great example of how we try to link together the standards that are used technologically as well as semantically. So I think it's not only about being fixed, like if you had a project just looking at semantics, and then over here at the other office you have another office just looking at what FIRE models you should use. No, you need to bring everything together because they are entangled. This is an example of how you adapt SNOMED. So this is an example where you can see there are 3 different extensions that have created a very certain allergy that is important to be recorded nationally. And they align it by making sure it is well integrated into a local extension or a national extension in this case, and it points to an international concept. And I was thinking of the babushka dolls, right? So this is the same if you go to a national level and you have local organization or local implementations, you can also create local concepts, making sure that it aligns to the national dictionaries so that it can be reused and understood across the country. In this case, however, if you are sharing the international concept or the national agreed concept, there may be a lack or a gap of, you may do some semantics, but at least you will know what type of the nationally agreed content that you will be, that you are talking about here. And then this goes a bit into the technical part, but this is an example of you can create locally a certain, this is an example from an allergy data entry form. And this is just to show that SNOMED CT is not dictate how things should be documented. Each clinical setting can design and apply SNOMED CT just as they would like. But on the back end, the representation in the combination of a standard format and SNOMED CT will allow you to reuse across the various organizations who want to share those data. I will stop here, just making the fact. So it's about starting to eat get the overview of the elephant and figure out what are the parts that you want to use and adapt them to your local needs. So it may be that you agree on some national standard or a general standard, but then train the implementers locally to make sure that they know what power lies in these various standards in terms of customizing them into their local needs. But remember the alignment, that's the key. If we want to make sure that we can reuse, make sure that it always aligns back to the standard that has been agreed and published in the national strategies. I will leave this here. I got time? Okay. So one approach, often systems or local implementers, as Sofie and Mark was saying, well, the systems are not equipped to just tomorrow start to use SNOMED. And we are also at this organization thinking about, well, how can we support local implementers? And I think building national building blocks of models that has the terminology binding, so that, let's say with the allergy example I showed before, in an allergy group, they can define, well, this is like a common practice for recording allergies. They will specify the terminology that is used, they can specify the models, and you can actually represent it in these reusable and implementable artifacts, so that each organization does not have to invent everything. Often like a national dictionary has been published in spreadsheets, it's been published in PDFs, and the task then for the implementers is to look at these papers and try to put it into something that can be reused across organization. I think we really, in order to succeed here, need to spend the efforts a little more effective in thinking about it's good to have documentation that relates to a certain audience, but also facilitate the systems and the softwares. And one way to do that is actually to provide them with some directly implementable modules of tools. So let's say it's fire questionnaires. That's the example I had here. You can build fire questionnaires for, maybe it's an allergy entry form. It has all the bindings, so you don't have to specify them up front, and then the implementer can actually take that. But what if the system doesn't support the FHIR format? Well, they will know how it's represented. They can go to the standard, the FHIR format, and then they will know exactly how, if they were supporting it, it's represented. And they will know what it would take in their system, because they know their architecture, what kinds of integration they would need to do. They have a much better foundation than if they were looking at it on paper. There are fields that have like dependencies and constraints and different things. They would have that all represented in a computer processable manner. Hopefully they will support the standards, and if they don't, they will have to make the analysis. I think that's a key point and relates to what I said in the beginning. We all need to bend some, and we all need to understand that we play a role in this effort. Yeah. So the value of these implementable and standardized artifacts, I'll repeat while Kai, you come up here, is that they are reusable, they represent things consistently across the various contexts, and they can be adapted. So I talked about allergies, it could be nutrition, it can be laboratory, it can be many things, and they are implementable, purpose-driven, and shareable. I would almost say it's a good basis for some fair data, right?
Thank you, Anna. I think we're all going to be exhausted after this session. It's like a whirlwind covering so many different sections. I've got a technical capabilities section. I've intentionally kept it very light because you've got an onslaught of information coming towards you. So I think a key focus in this session is around standardization of data. And standardization, of course, enables data reuse. Data can be understood, shared, and used consistently when it's standardized. So we've seen a kind of pattern developing across Europe where open air and fire specifications are coming into play in a lot of different countries. Open air, I think, seems to be a great way to form clinical groups and engage clinicians and have that conversation about standardization for your country. And of course, they have got a decent set of tooling around engaging clinicians. I think that's where it shines. And of course, they need to be developed, with the fire standard in mind. And we know Belgium has, published many fire implementation guides for different areas, including allergies and many others. And of course, once those standards are established, they need to be served and make it easy to implement. So having a terminology server, both probably a national server and a local server. A lot of this information was covered in the long fire call earlier in the week. And of course, once those standard around the information model and the terminology bindings are established, it's down to the EHR systems to implement those. I think it's easy to not change the EHR and think we can do it afterwards with, a health information exchange. It's likely that transforming the data afterwards is going to reduce the data quality. So if you can try and match the national standards as close in the EHR as you can, then there's going to be less transformation going on when it comes to interoperability and sharing the data wider. This is another tooling slide. So SNOMED International have many open access tools to facilitate terminology standardization. So when creating specifications for a nation, it's likely that some customization of the terminology is necessary, both language, maybe you need to add codes, maybe you need to create maps. So again, all that technology and tooling is available. This is my last slide, and it's about engaging with vendors. We often, when we come to do implementation support in different countries, we have a lot of pushback from vendors. Often they have big systems, they're very well established. They don't like the idea of integrating with a terminology server. I think it's important for organizations to lay down the requirements for the data standard that they want, but they should be flexible with their vendors about how those vendors can meet those requirements. So it's not necessary to interface with a terminology server directly. There's a few ways. So you may have a vendor, we've got on the slide, EHR1. They're probably a new and modern vendor. They're very happy to interface with the terminology server using the API directly. That's kind of ideal. It's kind of less work for them if they can do it. Another, probably a less common middle ground is EHR2. So they can actually interface with an API for terminology server search, for example. They don't need to rebuild, very nice search capabilities in the EHR. They can leverage a terminology server off the shelf, but they may still have some restrictions, like they can't store SNOMED codes locally, something like that. So you can end up with a hybrid approach. This is actually an approach I took 2 years ago when implementing the Barmany project. They could use an API, but they couldn't store SNOMED codes because they had an internal representation of codes. They had some restrictions. So we ended up with a hybrid approach. And the last one is very common with big vendors. They would say, no, we can't use a terminology server at all because we have to store everything inside our local database. And I think they can still use a terminology server. We need to, provide them ways of doing an export, transforming into their formats and ingesting, but you need to let them know that this terminology is likely to change regularly. Make sure you create a reusable pipeline so that it's low effort to update the terminology. Alejandro.
And how we can make all this work together? This looks really complex, so the things that we need to do to achieve a successful implementation. And like the presenters before were saying, we think that the clinician involvement is fundamental for that. So we need to have some goal. We need to have some metric to see where are we going. And what we want is to have the best possible coding quality, like Anna described. So we need to have all the possible attributes of coding quality right. And to improve coding quality, you have two strategies. You have the carrot or the stick, right? With the stick, you can beat in the head at the people who do it wrong, and then you need to do like manual reviewing of all your records and say, oh, this is wrong, this is right. And you push people to do it right. Or you can make it easier. And the stick are incentives. And many of the incentives are related to the comfort of using the system, how much time you spend, if it gives you information back, if you get some benefits from the information you record. It's more difficult to create incentives than to use a stick, but it's more sustainable because the stick is really expensive to maintain for a long time because you probably need to spend a lot of time in audit and meetings with people and things like that. So what are good incentives for clinicians to code right, to code well, to improve the quality of the coding? And the first one is that this is fast. This doesn't intrude into my workflow. And describe that it needs to be flexible. It doesn't need to be a single way. But ideally, the system should also predict the actions and provide shortcuts, provide suggestions. You need to make life simpler. If possible today, automatic coding assistance is a must. Yes, we're advancing with LLMs into the AI world of AI scribes, like we saw in other presentations. So probably some kind of automated coding assistance is in the future for most of us, that you don't need to type everything. We just need to correct what the AI thought will be the right code for this consultation. Also, we need to have good coverage. Yes, we need everything that the doctor looks for needs to be in the terminology. And the search needs to be good. We need to have good precision in the search. We need to have good sorting, so the most important, most relevant concepts are on top. And then we need to provide the doctor with point-of-care benefits. Yes, we need to provide intelligent feedback for each patient. We need to provide decision support alerts. We need to provide good summarization that depends on the quality of coding. We need to link to knowledge resources like internal hospital guides or reviews, meta-analysis, recommendations from different associations. We need to highlight patterns that the doctor may have missed. Also, we can provide with population analytics. If I'm a family physician and I have 1,000 patients on my care, I need to be able to manage that population, understand what's happening to them. If I'm a surgeon and operated into 500 patients in the year, I need to be able to understand all those operation events and understand how they done, what was their progress, how they are today, and things like that. You need to have a feeling that these are my patients and I have a grasp of the patients. Saying this is simple, but doing this is really difficult because it involves designing the interaction with the doctors, designing the software that will provide these benefits. Design is complex and the doctors need to be involved in the design. And always the bottleneck here is the software development. We can design a very complex thing, but when we sit down with the software developer, they say, no, this is not possible with this tool. So we keep doing what we had before. So the only way to do that is to plan things ahead in a very specific way. Yes, we need to be able to get the right specialist. We know it's not easy to get design specialists, but you need to get that. You need to get time from physicians. We know it's not easy to get time from physicians, but maybe we need to pay them to participate in or assign time or save other responsibilities of the physician to participate in design. We need to be able to reuse experiences from other places. We don't need to start over in each hospital, like each hospital was unique. Of course, we need to ask the doctors of the hospital, but not starting from scratch. It's good if we have some good practices that can be shared with everyone. And when we go to the software developers, yes, it's important to help them with tools when they need to have like architectures, paradigms. They need to have open source tools that they can reuse. We need to have very good descriptions of the behaviors that we want to do. Yes, so we need to provide a good experience to a software developer as well, so he can update the software in a way that fulfills our design goals. And then we need to work with the doctors as well. We need to help them adjust to our changes. Yes, people, everything wants things to get better, but never to change, says the thing. So we need to sit down with them and explain why these screens look like this, what are the benefits. If you do this, you can get this benefit. This is how you search, and this is how you use this technique. We don't believe that every doctor needs to know about SNOMED, but they need to know about their system, and their system needs to take advantage of SNOMED and present the benefits. But we need to spend time with them so they can get the best out of that system. And when they have a problem, they need to look to the right and see someone who they can help. Yes, maybe someone in the hall, maybe the nurse, maybe someone. So they need to have the right level of support. So in SNOMED, we are working in this toolkit that support this kind of implementations. Yes, for the design, we have clinical implementation guides, we have clinical reference groups where clinical experts get together and try to define these designs, like Anna showed in allergy, for example. We have value sets. We have people who got together and created value sets for nutrition, for different aspects, and you get the value sets already created there. We have workflows explained in our clinical implementation guides. We have real-world experiences shared in groups like this. Yes, we have a site called SNOMED in Action, when you can find real implementation experiences to inspire on. And we have demos. We have software demos in which you can play and you can see this is an experience doing analytics, this is an experience loading an allergy, recording a problem list, or something like that. And with that, you can go and sit down with a software developer and you get a guide to show to him, very structured guide that is easier to understand for a software developer. But you have tools to show. You have libraries, you have open source software, you have the technical implementation advice documents. You have courses also that the software developers can do to understand SNOMED better. So you have a series of tools that will help you when you sit down with your design with a software developer. You have things to help you overcome the conflicts and challenges working with developers. And then when you go and sit down with the doctors, we need to create these clinical guides that help people coding. But although this may be very tool specific, you can have generic ones, but maybe after you design something, you need to promote the design you got, yes. So you need to have also content development strategies that support implementers. So how to help an implementer to say, okay, what happens when the clinicians find a gap? How they report that gap in the missing concept or a missing synonym, and how do you add that content quickly into the system? Maybe you create an extension, maybe you have value sets, maybe you have other strategies. So you need to define those strategies that will try to cover the clinician found gaps. And also it's easy if you can give the clinicians the possibility to modify the screens, to create forms for themselves, to create fields, and in a way that those forms will still be interoperable. So we have this site, the EHR lab site that we'll find in the SNOMED demonstrators that have examples of this. And these kind of sites will help you try different paradigms. And we are also hoping that we will receive feedback from members saying, oh, I have these ideas to summarize information in this way, or to enter information in a problem list in this way, or to filter procedures or prescription in this way. So we are looking forward to create more like a library of good experiences, of good interfaces that will help you in all these phases. In the design phase, to have ideas and try them. In the developer phase, to inspire developers with real-world code that they can copy and reproduce. And in the clinician space, so they can learn about how to improve the way they work, and they can see the benefits they can get from tools like these.
Thanks, Alejandro. I'm going to talk a bit about the national use cases, common national use cases for secondary use of data, and how the policy can support that. So there's many common use cases for national reuse of data. Like it's a desirable thing to have. wide-ranging use cases. So researchers accessing large amounts of, real-world evidence data can deliver a lot of value. Surveillance, like national surveillance, and patient safety monitoring, so around drugs, procedures, other things. The data can obviously help to influence policy. It can deliver quality improvements through monitoring and adjusting to healthcare. And there's a range of mechanisms for that. So it's clear that reusing data at a national scale can deliver huge value. So, of course, to achieve this vision, well, you need a strong national vision, and I think Belgium definitely has that. And of course, you need policy to back that up. There's been a lot of talk already this week about the European health data space. Of course, everyone knows it's coming. And that's really designed for use, for reuse. So nations need to designate a access body so that people can apply to access the data for reuse. My monitor's just gone off. Oh, it's back on again. All right. The principle of secure processing environments. Like policy isn't just about making people do things and making sure you get the right outcomes. It's also about building trust with your nation. So making sure you've got transparency, you've got safeguards in place, you're empowering patients. The secure processing environments where the data isn't copied around, but it's actually kept in place, and researchers come and access it, but don't take anything away. I mean, this is brilliant policy where you can build trust and make people more relaxed about, this is okay because everything's being done securely. And of course, the policy around expanding cross-border exchange. So already, this aligns with a lot of policies that many European countries already have. So around access, for example, many European nations already have a secondary use law and policy. For example, FinData in Finland is the single permit authority to access data for research. There's many secure processing environments, and it's part of UK policy as well that when you're accessing data for research, it doesn't leave the environment. It's the same in Denmark and others. And other enablers in this area are having national identifiers and having patient consent. Again, this is about empowering patients and having safeguards and being transparent. In the UK, they have a policy where there's a national data opt-out policy. So by default, your data is available for research, your healthcare data, but it's very easy to switch it off. You can go into the NHS app and you can go and opt out. So people feel empowered. And they found that because people are empowered and they know they've got access to switch off the button, they've kind of relaxed and they feel like it's okay. And the opt-in, default works well. There's a little graph on the side, and it really shows that over the last 20 years, when we look back, there's not been a lot of policy across countries in Europe about data reuse. But in the last 10 years, it's really, ramping up, and these policies are coming in thick and fast. Hopefully it all aligns. So I think we're approaching a world where huge amounts of data are available for secondary use. And of course, we need tooling and standardization in that area too. I think there's an opportunity with collaboration with the Observational Health, Data Science and Informatics organization. I know it's funny because I talk to some people and they're like, yes, we're already using this. I talk to others and they've never heard of it at all. So it's good to socialize. So the Odyssey group and the OMOP common data model is rapidly growing in popularity. for a number of reasons. They've got a rich open source tooling ecosystem, allowing you to transform your fire data, for example, into the common data model for research and secondary use. Has regulatory support and industry support in many countries. There's also engagement from a lot of notable academic organizations, Columbia University, Stanford, Oxford, and participation in Korea as well. So OMOP does provide structural standardization, so the shape of the information model, and semantic standardization, so the terminologies you're using. And there's an OMOP standardized vocabulary, which is kind of very aligned with SNOMED and LOINC. So if you're already using these standards, it's likely that the transformation to Odyssey is quite painless. There's not really much to do. It focuses really on the most common use cases for general clinical care, but there are specialties supported as well. There's extensions to the common data model for oncology, genomics, radiology, dermatology, many others. But I think standardizing the secure research environments and the formats those is kind of crucial as well, because you might have access to data, but if you can't use it because it's not standardized and you don't understand the formats, then it could be trouble. So the implications for getting this right are of course huge. The kind of three areas of data research, data use, reuse are research, public health, and innovation. So, I think this is the shared vision of many countries, that in the research area they'll have accelerated clinical research through access to standardized national data. They have precision and reproducibility of the science. It won't be different scientists transforming the data in different ways if it's already been done and it's centrally accessible. You can read the slides. There's a whole list. Clinical trials are faster and easier. It unlocks capabilities in AI. Many benefits in public health around the timeliness of the data access, cross-border interoperability, and many in innovation. So yeah, huge value to the ecosystem. And this is the kind of ideal common vision, I think. So we're going to move away now from the very high level and ideals and back down into some concrete examples. I'm going to hand back over, I'm not sure who's next, I think it's Mark. Thank you. Who's phone? Don't know.
So, next steps in Belgium. When we talk about the steps that need to be taken in Belgium, we can look at them from two complementary perspectives. On the one hand, we want to present the field-driven proposals. And after that, Tom will present the next steps from the government perspective. But let's start with the field-driven proposals. In the gray box at the top, you see the preconditions and enablers that actually correspond to the secondary use challenges that have been previously explained by Sophie. It's things like ensuring verification of data, ensuring the only ones principle, ensuring the data solidarity principle. But we do want to go into 4 additional prerequisites that we find equally important, and we'll go into a little more detail in them now. It has already been said, what we need is actually a national common health data model, one that is useful for primary use exchange and for secondary use exchange. What is it? It's a standardized framework defining how to record, name, and exchange data, and we have to agree on that. And all federated data sources, which are often proprietary information models, must map to this common health data model. Why do we need it? Because without such a common health data model, the same information may be registered in different ways, leading to possibilities of misinterpretation away from the source. And happily, we see in Belgium that the RISIF is already building in on this common health data model by the so-called care sets, which are the Belgian variant of the clinical information building blocks. The second field proposal is that we should try to achieve the goal that all stakeholders actually acknowledge their role in the health data ecosystem and that all take their responsibility. And there are a lot of stakeholders. There is the medical education institutions that should train future clinicians on structured and coded data entry, should make them aware of what FAIR principles and interoperability is. The clinicians themselves are, of course, a stakeholder. They should do correct and consistent recording of priority data elements within the EHR. Of course, there is a quid pro quo. The ecosystem must provide them with tangible benefits for doing this. The Belgian National CMIO network should ensure clinical anchoring in digital health decision-making by government, and it should coordinate the implementation of standards such as SNOMED CT. Vendors should also acknowledge their responsibility. They should really embed only once as a core design principle, not just the standard, but also within the functionalities. They should align with standards and implement interoperability more proactively, and they should not monetize it. And they should support AI agent-assisted structured data entry, making it or creating a lower threshold for clinicians. There's also responsibility in public health authorities. They should lead by example. They should make their own data sets fair and compliant with the standards that they impose on others. And they should also think of how they can provide financial and technical support to enable healthcare providers to do the same. And finally, all data reusers have the responsibility to provide feedback to the data holders on the quality and usability of their data, so we close the circle and improve the ecosystem. The third proposal is that we think there is the necessity for a health data ecosystem architecture function. Because the concern is there are multiple stakeholders, they all have their own objectives, they all work under their own mandates, so that risks of creating siloed efforts which are poorly coordinated, and there is also always the risk of ignoring the interconnectedness between primary and secondary use. Such an architecture function can develop and proclaim an overarching vision, can safeguard the architectural principles, and can ensure that all efforts converge towards the intended ecosystem. The final and last field proposal is clinicians should be unburdened. They should be empowered with AI-driven clinical documentation tools. Provide them with these tools that help them to transform free text into structured core data elements. See that these tools are optimally integrated in clinician workflow, and make availability of such tooling an EHR certification criterion in Belgium. Then, once these tools have structured the data, ensure immediate interoperability, availability of these structured data for primary use purposes. That's the clinician benefit that's needed. And simultaneously, these structured data can be leveraged for secondary use, for example, by anonymizing them and storing them according to the Common Health Data Model in local repositories that are available for federated analysis. And with these field proposals, I give the word to Tom for the government view.
Whew. A lot of slides, a lot of work, a lot of stuff to handle. Do we as a government have a strategic view? Yes, we do. And in the Open GA, I explained it more. Here are some highlights in where we see that all the government bodies, such as the Federal Public Service, Health in Belgium, the National Insurance, Health, how do you call it, for disability and health insurance, which is needy, Cienzano, Health Data Agency, etc., wants to go further and perhaps from time to time tackle the concerns and the proposal that Mark has just put forward. Of course, the implementation of the European health data space is one of them. It's a big chunk that you have to cut into pieces and see whether, okay, where we go, where do we want to go. The principles in Belgium are very clear on that. We want to go with FHIR, we want to use semantic standards like SNOMED CT, LOINC, and as Mark already touched upon, care sets is for us also the structured way to send the data around. If it goes fast enough, no, but we'll try to get it faster in the coming years to get that also going on. What we see also in the European Health Data Space Directive is that software vendors must oblige to the requirements that will be put forward in the European health data space to get access to the EU market. Does that mean that we as a government has to wait for those requirements? No, because the requirements are under discussion for the moment. They are not clear yet. So we have to make sure that we can talk to software vendors, make them oblige to do the things that we want them to do. And that's the second point, the Belgian integrated health record. Certain things of that we must make legally binding. We must comply, that everybody must comply to the law in Belgium. Why is that important? Not only for software vendors, and I hope that's what I'm saying now, Mark will comply, but also for hospital management. Hospital management will only, that's the most thing I hear, will only move when it's in legal binding, and for the moment, and that's what you see in what Mark has shown, mostly they do not want to move because they also look at the money, they also see, okay, what's in it for me from a management point of view. We're working in the Belgian government at an architectural layout of the Belgian integrated health record to show everybody what we're thinking of, to see, okay, where are we going and where do we want to go? And I already received emails to get ready when we're back in office to draft a new eHealth action plan and to get the concrete steps that we want to take there in order. We're also working on the implementation of a new register policy based on the principles of the European health data space. I won't go into it further because a lot have already been said here. We want to also implement coherent and streamlined incentives system for health professionals. We're working now on discussions internally, and normally in 2026 our minister will approach the health professionals to see, okay, this is those are my ideas, this is what I'm talking about, do you agree or do you disagree? So a lot of discussion will start from there. And I personally am looking at a structured way of financing digitization projects through more structured ways. Not, as I shown in many presentations this week, we have data capabilities projects, innovation projects. The name says itself, it's a project. It has a beginning and an end. I'm looking here at seeing, okay, how can we structurize certain things in order to be able to develop AI agents or whatever that's needed in hospitals to get also that train going on. So more to come in the coming months. I say a lot in the coming months, but it's really in the coming months. Another thing that we want to touch upon is towards patients. Get that platform, what he said here, myhealth.be or health.belgium.be, dus mijngezondheid.be in order. We also do want to communicate more to civilians and to a patient through the health data agency to get that digital health literacy up and running. Embedding the standards into law is something that we're looking also to. And for, but not most, the latter is that we also want to look at cybersecurity. We're putting a lot of effort for the moment into hospitals to make sure that they are applied to what we call in Europe the NIS2 directive, which makes a hospital a critical infrastructure. Such as a government is also a critical infrastructure. That means that hospitals do have to put a lot of their effort and a lot of their energy in cybersecurity. If you combine all those things, and I'm sure that we have to adapt as we go along because we cannot tackle it all at once, I hope that we can make sure that by 2029, we will get there at a point, Mark, to give you a positive message. I will not go that far in saying we will be there, but we will be a long way already. So let's conclude here. And I think that's my last slide. Over to you.
Well, I want to thank everyone who participated of this presentation. I think it's great to see Tom and David and Catherine that work with us to prepare this, Mark and Sophie presenting the real world experience, Kai and Anne and me presenting the SNOMED view. From SNOMED, we learn from these experiences. We learn a lot about understanding challenges, evaluating possible solutions, and we will learn more from what you will do in the coming months to see how this is progressing and see the results in a few years. Maybe if we were able to change this reality, that will be very useful for a lot of countries that are going through the same process. We invite everyone to visit our resources, the courses, the implementation tool, if you're country representatives, use the member forum to exchange this kind of experiences. This is really, really valuable. And I think also this presentation may be valuable for Belgium implementers and hospital managers in the country that want to see how this is going, what are the next steps, what opportunities are in the future, and also vendors and so forth like that. So I really thank you everyone for the participation. We hope that this is useful for everybody. Sorry, we can open to questions. We can go to the question slide. Questions from the audience to any of the presenters. You can ask to the government presenters, hospital presenters, or SNOMED presenters. Yeah. We have a question there.
It's Mike.
Thank you very much for a great presentation, great work. Belgium, you've done a great job. I have a question maybe to Tom. You did mention something about a unified record for Belgium. Are you talking about a single record, or you're talking about something similar to an HIE, Health Information Exchange? That's 26, 29 effort where you need to unify medical records.
The Belgian integrated health record is not to unify electronic health records. We in Belgium will leave the opportunity to the hospitals to choose whatever they want to choose on their electronic health records. The Belgian integrated health record is a vision where we want the information flowing around. So the architecture is not laid down to the hospitals, but it will be an architecture where, for example, the Ante server will be the authentic source to be used by everybody in Belgium. Having said that, there will also be requirements for electronic health records to oblige to, above the ones that will be mentioned or are in development within the European health data space. So it's a combination of both. But we will never say to a hospital, you have to have that software, at least under this minister. Let me put it that way.
Anyone else? Questions? Yeah.
I think some of the Belgian government representatives touched upon this briefly, but how do you incentivize EMRs to actually implement this? Because in Latvia, we also know working on making SNOMED mandatory as a clinical terminology. And we see that the EMR providers just don't really do anything until there's pressure from the hospitals, and hospitals don't really want to apply that pressure because they don't want to change their workflows themselves. So, you know, could you, I understand that the stick would be some legal mandate, but what does the carrot look like?
I'm going to run.
If you're talking, if you're asking that question for me from a legal point of view, there shouldn't be any carrot. It's a law. Everybody has to oblige to it. If you look at a financial thing, yes, the carrot will be incentives to make sure that, and that's what I meant with the Belgian meaningful use criteria. Those are the incentives that we want to put forward to get the hospitals working on that to make sure that they oblige to certain things. Well, that's when you go to the grocery and buy an apple, it's the same thing.
Oh, Raymond, this one.
Okay. So if you give money to a hospital, then that's a government point of view. If you give money to a hospital, we want them to make sure that they use the money for the right way. That's not happening for the moment. So that's also a change in the vision within the Belgian meaningful use criteria, that we really want them to give money and that they have to prove to us on certain criteria that they're doing the right things there. If they don't do it, then the vision is also that we could cut down the money the year after. So that's the carrot and the stick at the same time, because otherwise they will never move. And I see it, I'm saying it now cornered, or court, I'm taking the corners very, very short now, but that's the idea behind. It's easy to say the pressure is on, but the pressure is really on here, because we have to oblige to European health data space, so we have to get everybody in a certain way moving. There's no way back.
Hello, good morning. My name is Ineke de Laat. I'm the CMIO from SAS also. I understand your point about the Belgian meaningful use criteria money that is given to the hospitals, but the EHR vendors now, they sell interoperability to us as an optional feature that we have to pay for. When we are telling them in the EHR, the future, if you want to have a viable product in Europe, it will have to be a standard feature. So if you would oblige the AHR vendors to provide it as a standard feature, then we can use the BIMIC money to develop the AI agents that we need to optimize the workflow. So we do need the push from the governments towards the EHR vendors to make it compulsory to provide this interoperability, because now they monetize it.
I agree.
I also agree. But my point here is also that something that we are talking about this in the SNOMED member forum quite a lot, about how is it that we get the vendors buy-in on SNOMED and standardization, because they can be very fixed. And I think the place that we can really as an organization contribute is really to help members who can then help the implementers in their procurement processes. I know when you are in a country where there have been EHR procurers, then you need to go with that, right? But for new procurement, there will be new procurement processes. And in that, you really need to be clear on your requirements for terminology and standards. It's not enough to say we wanted to support SNOMED or LOINC. It's not enough to say it needs to support interoperability, because then you will get to the point where they say, well, we do support it. Yeah, but I want this feature of SNOMED, and I want this capability, or I want this interface or a message model. You need to be so precise. And we do have some reference documents that you can refer to. And I think this is really what needs to go out to the individual implementers who are procuring systems, that it's not enough to just say we want this standard. It's actually also providing the very specifics about how those are applied. I think that's the role, and that's not the role of the governments, that's the role of those procuring systems, to actually put pressure on vendors to say, well, maybe you say that you support a terminology or an interoperability standard, but we need you to show that you do it in this and this way. And this way should then be the ways that you require locally in terms of the use cases you have.
I suppose the same is true if you've got an EHR and you're going on the journey of having a new feature, that it's not a tick box, is it? Interoperability or not. Anyone else in the room, or any comments?
We've heard a lot on AI, and I think we've heard a lot on that there is really necessity for AI agents to support clinicians in forming the basis for a SNOMED CT encoded repository in an EHR. You as SNOMED CT, you are providing quite a lot of different types of toolings. Has SNOMED CT thought about providing these EHR agents as these could function for very basic use cases, such as, for example, extracting IPS elements from free text letters? I mean, that's the use case I would think that is the basis for all the other things going on top. And we see a lot of what I often call exotic things where I think we don't even have the basis in order. So why not start with the basis? And how does SNOMED CT think about that, of providing this?
So we have done some research in this area over the last couple of years, and we have created a couple of demonstrators in this area as well. But I think now's probably a good time to revisit it. We have to be careful because we've got to kind of respect the vendor ecosystem, and that they want to be able to sell you something that isn't already available open source. So there's a kind of a balance. I do think we can outline best practices around avoiding LLM hallucination and how to interact with the terminology server so that you're getting proper SNOMED coded data, probably under the constraints. But I think we probably have to do it like a design level, like a template. This is what you can follow, make it easier for them, but probably not actually providing the solution that's kind of production ready. We can only go so far, I think. But yes, certainly more examples would be good.
We're exploring the UI, possible UIs now. We're in the process of thinking about how the UI will look like when something is read in real time, the free text, and the entities are recognized, and you have the power to incorporate that into the clinical record. And so this is something that we are showing and playing with members to see how we can have like these best practices that companies that can provide this as a production thing can then work and make it real.
Hi, thanks for great presentations. So kind of along that AI thread of thought, reducing physician burden. One of the uses is, say, using a cell phone for text-to-speech conversion for scribing, except that that data isn't being done on the phone. It's actually being sent off to a server to do that conversion and then coming back. So from a regulatory IT perspective, are there things that are outside of healthcare regulation that governments need to be taking into consideration or possibly implementing before we can consider expanding the use of AI in healthcare?
Yeah.
My understanding about the AI scribes is the latest AI scribes that I was having some conversations yesterday. There's some under trial in some UK hospitals in London, and they don't actually code the data. They're really just taking clinical notes. So whether it happened on a phone or elsewhere, I don't know. And you're right, there's a concern if it's on a personal device. But yeah, they're not actually coding your data. That is on the roadmap. It's one of I know there's some implementations that do that, but I'm talking about like the tier one, the big Oracles and Epics. That's on their roadmap, but it's not happened yet.
Yeah, and local LLMs and AI systems is much more reality this year than last year. So I suppose that in the coming years, running the system locally in a server or even in your own phone, like Apple Intelligence is running an LLM in your phone. So it will be more and more possible.
I was talking to a clinician, not even a clinician, a data scientist at one of the hospitals in Belgium who's part of a clinical network, and they are looking into ambient listening, which is getting away from the screen and the clinician looking at his patient and talking to the patient, recording everything indeed with the microphone, putting it back onto the data. That's of course, and the evolution of these technologies are going at an incredible speed, that on a daily basis. So I think it's a rather tricky situation. I'm fully aware of the quality issues. I was talking to the people from Health Data yesterday about it. They said, well, if they say 60 or 16 and you record it wrong, it could be fatal. So that's just one of the many issues. But it's a tricky situation because you indeed want to stick to the core components that we know and that are quality assured, and then we don't want to miss that train either. And so it's a challenging time, I would say.
And I think this is exactly where the AI, because some would even argue, why do we then need a terminology when we have AI? Because it can categorize and do everything for you. But for that exact reason is why we need the terminology. Because we will, and I can't imagine how many years that will be, need in this world of artificial intelligence, need the clinicians to actually state, yes, this was, or confirm what the engine has derived. We need that human validation in order to make sure that the principles that you so nicely described with FAIR principles, that they are kept.
Any other questions, comments? Okay. Thank you very much. Have a nice day. And we are a bit early for lunch, so we have 10 minutes. Thank you.